I wanted to welcome everybody on behalf of PreludeDx and the Decision RT score. This is great to be here and actually be at a conference where everybody's not wearing a mask. 2 years ago was the last time that I think we all kind of basically got together, and it was happening right about this, where the whole world got ready to shut down at this meeting. So it's kind of deja vu to be here. So we're very excited to have such a wonderful group here. We have three wonderful speakers. I'd like to introduce Dr. Troy Bremer, our founder and chief scientific officer, Dr. David Rock, who is our precision certified doctor here with Genesis Care, and Dr. Jim Pellicane, who hasn't been outside of the pool the whole time he's been here, by the way. This tan did not come easily. I just want to let you know that. It's all good. So here's what's going to happen tonight. We're going to go over some data. Very excited to kind of share what's been kind of a long situation for us to be able to get SWE published. So we're going to talk about that. For the people that are brand new with the data, great. We're going to make sure that you get very comfortable with it. For the people that are familiar with the data, like Karen out there, what we're really going to be talking about is implementation. What's been fun over the last really 6 or 8 months or so is that with the publishment of SWE, we're no longer talking to doctors about prove this to us now. Now it's how do I get my RADONC engaged and how can I work through that with an implementation process, right? So what we really would like from you all is at the end of the night, if we could kind of find out from you all, who are your RADONCs that you deal with, right? That we can go and help give you those information and ammunition in order to kind of help drive that, right? So we've got one sitting at the end of the table who's a believer, so we love that, which is good, right? So hopefully tonight we're going to go through case studies and the data, so have fun, enjoy. I know Troy likes to make sure that it's very open.
So my disclosures for tonight is I'm the founder and chief science officer for the company, and I have had the pleasure of working with the development and validation of this test for over a decade to bring it to where it is today. So again, I really appreciate your time tonight. So first thing, we got to take off our invasive hats because we're often wearing them. And this is about stage 0 DCIS. So this is not about survival. This is about recurrence. And this is about what happens over a 10-year time frame, not 5 years. And of course, this is non-invasive. So this isn't METS. This is a local recurrence question. So margin status and whether or not it's coming back and how much do I need to prevent it from coming back. And of course, I want to point out a couple of interesting ideas. Today, most people are treated with breast conserving surgery, and about 80% of people treated with breast conserving surgery don't recur without any other adjuvant therapy. And yet 80 to 90% of patients are treated with other adjuvant therapy, including radiation therapy. So there's a mismatch of we can't quite figure out who the right people are. And so we have to be more conservative in how we're going through the treatment cascade today. So our job is to help with that. So what's needed? And it's really a better tool to assess risk and benefit from radiation therapy. So what we're doing is both identifying the risk profile for the patient after breast conserving surgery and also identifying how much benefit they can expect from radiation therapy. And the combination of that helps you make a much more informed treatment decision to personalize management. And of course, that is the goal, as in many drugs today. This therapeutic is radiation, and our goal is to be able to personalize that therapeutic. So when we talk about this, we have tools that we're using. And this is really part of the tree of decision making. And that is it just breast conserving surgery alone? Do you need something more aggressive? Maybe it is mastectomy for some patients. Do we use an AI or TAM, or is it radiation therapy, and what combination is most appropriate? So the first thing is, based on the data that's been published, we've been able to partner with about 70 different institutions across the United States as part of a registry study for clinical utility and 5 and 10-year outcome that will be monitored. So in this study, what we showed is in routine practice, more than 40% of the decisions about radiation therapy recommendation were changed. So about 70% of the time, patients came with a recommendation for radiation in the study, and many of those patients were then not recommended radiation, but on the contrary, the 30% who were initially not recommended, about 40% of them ended up with a recommendation. So patients were moved dramatically to either receive radiation they would not have or not receive it, to the tune of almost half of the patients are being impacted. We recently updated this and presented at San Antonio in just under 1,000 patients, and we found the same result. And so now we have a number of different validations from a number of different sites showing about a 40% impact in treatment decision-making. So the test is designed to try to make this an easy conversation with the patient. So the reason it's simplified is because the patients are coming in, they're often having a first conversation. They don't understand their risk. They're not sure what DCIS is compared to invasive. They have a lot of anxiety, and we're trying to provide the tools to be able to provide the risk and the benefit. So the top line is that we give you a score from 0 to 10, and that score is translated to the individual risk profile for that patient based on their biology and clinical pathology. We present on the top line patients that are treated with breast conserving surgery only. What is their risk at 10 years? We present both the total component, either a DCIS or an invasive recurrence, and just the invasive component, because according to NCCN guidelines, the goal of this is to prevent those invasive recurrences, because of course we don't want to get into the hopper again with chemotherapy and other downstream sequelae. On the right-hand side is a patient with an elevated score of 6.8. What this is showing is that these patients may have pronounced risk, 30% going down to 9%, for instance, which is different than what you would otherwise expect. In all of the prior randomized studies, after breast conserving surgery, we expect about a 50% reduction in risk with radiation therapy. What we've shown in each of these studies is that it's 70 to 75% for the amount of reduction for about half of the patients. So what that means is that we've identified about half the patients who are getting twice the benefit, and the other half of the patients who are getting minimal to no benefit from radiation therapy. So what the test is doing is taking a series of different biomarkers, and these are covering the major components of growth, cell cycle control, the different types of interactions that have to do with stress response. And of course, you also have clinical pathology that's added in there, so that when you get their score, it's a comprehensive result for risk that you can use to make a decision. You're not having to piecemeal this together. This is combined with nonlinear AI algorithms. And those algorithms are using not one marker at a time, but combinations of those markers to describe pathways. And those pathways are what's creating risk. What this does is it leads to our assay, DecisionRT, which is again, ion radiation therapy in terms of making those decisions. The score is on the bottom. I know we're used to seeing Kaplan-Meier's, and we've seen a few of those during the conference, but this is not 10 years. This is a score from 0 to 10 from the test. Those patients who are on the left side in the green, this was a predefined threshold of less than 3 to identify patients with an average result of 10% or less at 10 years with breast conserving surgery alone. On the right-hand side, of course, is the other group where it's higher risk. And on average, patients with a higher score are about 4 times more likely than those with a low score to have a recurrence within 10 years. When you look at this, though, it's on an individual patient basis that we're reporting out the results. So some patients may have a 30% chance of recurrence, and some patients may have a 10% chance of recurrence, as we're in this elevated risk score group. So it's not just one number, it is a continuum. The important thing is that we're not just providing the top line in blue, which is what the risk is after breast conserving surgery. We're also providing the benefit from radiation therapy, which you can see in the orange line. They're not parallel. That means as you go from the left to the right, these curves are not just proportional, they're quite different. The higher the score, the bigger the difference there is, and the more benefit that you're getting from the radiation therapy. There's one exception, and that's on the very right-hand side when there are just a number of different pathways that are all involved to give a very high risk. You could see that it tips up, and you're still getting more residual risk after radiation therapy that you might like. So there's a subset of patients with a residual risk group, a very high risk of recurrence, even after radiation therapy, that you need to pay attention to. So we're fortunate that we have a number of publications that we're going to talk about briefly tonight. The first is from Uppsala, Sweden, and the University of Massachusetts. And we just showed you the continuous risk curves from that study. We have an independent validation from Kaiser Permanente Northwest. And of course, we have the published SWEDICIS randomized clinical trial, which is a prospective retrospective assessment. When you look at this in aggregate across these studies, it's about 1,500 patients. And if we look in the top line here, the question is, how much benefit from radiation are you getting in that low risk group? And what we're showing here is a 10-year risk profile. And you're seeing that for an invasive risk reduction with radiation therapy, it's 1 to 2% difference in the low risk group. So let me put that in terms of a clinical point. You're treating 100 patients to prevent one invasive recurrence. 99 patients are not benefiting. On contrast, when you're looking for patients who are in that elevated risk group, on average, they're getting about a 9% risk reduction across all studies. They have about a 70% relative risk reduction after breast conserving surgery with radiation. So when you think about that, you're treating about 10 patients to prevent one invasive recurrence. It's a lot more appropriate than what you're talking about for a general population trying to treat everyone, or the low risk patients where you needed to treat 100 patients to prevent one recurrence. I want to dig into a little bit of data from the most recent publication, which is from SWEDECIS. So this is one of the 4 major randomized clinical trials for why we treat with radiation therapy after breast conserving surgery. What was shown originally in this study is that all patients, independent of their clinical pathology characteristics, benefited with a 50% relative risk reduction after breast conserving surgery. And it's a radiation versus no radiation study without endocrine therapy. So 3% of the patients on this study were treated with endocrine therapy. What we saw in this study is that all of the different clinical pathology, the distribution in time, mode of detection, palpability, nuclear grade, size, they were all balanced so that the same distribution of clinical pathology was in the treatment arm with radiation or the non-treatment arm without radiation. So this isn't about differences in clinical pathology now. The difference was there was a 6% more likelihood for women over 70, a very small group, who had more likelihood of receiving radiation therapy than the younger women. But again, it's a small number of patients who had a different outcome in terms of their treatment. All of the other factors were very nicely distributed. So what does this mean? We're looking at a test now in a population randomized to receive or not receive radiation up front. And we're showing that those patients who had a score of less than 3 had, again, a 1% difference with or without radiation therapy for 10-year invasive risk. Again, that would mean you're treating 100 patients to prevent one event by including radiation therapy. On the right-hand side, it was a hazard ratio of 0.24 or about a 75% relative risk reduction. And again, a 9% absolute reduction in risk that was statistically significant. So these patients, again, are the ones nicely distributed with clinical pathology, randomized for treatment, that we're showing the test is identifying a subset who are getting twice the expected benefit. And the other group who's getting the scraps, unfortunately. The good thing is they started off low to begin with. So the patients who have the elevated risk are the ones who are getting the most benefit. It's great that it worked that way. It would be awful if it went the other way. I also want to talk about clinical pathology for a minute. It's often a question that when you have a patient who's younger or who presents with different nuclear grade or is larger in size, how does the test perform? Do we really end up with reclassification, or does that clinical factor, is it enough to make a decision on its own? So 50% is a coin toss. So anytime we're approaching 50%, the information you're getting from clinical pathology means it's near a coin toss in making a decision. So we have 56% versus 44%, low versus elevated for patients under 50. We have 45 versus 55 for patients over 50. Darn near coin toss. So the age is not telling you enough to make a decision about radiation therapy benefit. When you look at nuclear grade 1, 2, and 3, you can see a slight trend that as you go from nuclear grade 1 to 3, yes, the patients with grade 3 disease are more likely to be elevated, but a third of them are still going to be in the low risk group. And conversely, those patients that are grade 1, about 40% of those are going to be in the elevated risk group. So no matter if you're going from one side, the low, to the other side, high, you're reclassifying substantial percentages of patients with the biology that you don't find with the clinical pathology alone. So this checkerboard is trying to point this out. Even for criteria like RTOG 9804, 40% of those patients who met that criteria end up in their elevated risk group. And we'll show a little bit later that those patients are indeed at elevated risk and benefited substantially from radiation therapy. So again, 50% being reclassified, that wasn't just true for SWEDECIS, it's been true in every study. And it's been basically the same rates in each of the studies. So 40 to about 50% of patients in each of these studies, about 1,500 patients, are showing that if you look at low clinical pathology, smaller size, lower grade, negative margins, screening detected, just what we're all looking for, 40% of the time or more, they actually have really bad biology. It just isn't on the slide yet. That slide that we're all used to relying on is a snapshot in time. It's not a movie. I have today what it looks like, but I don't know how quickly it's changing by looking at that histopathology. I just know where it is today. What the biology is telling you is how aggressively it's being driven. And so that's why you're seeing the differences, is because it's not just from the last slide. So I told you that when you look at patients who met criteria, and these are the patients in those 1,500 who met criteria, so 539. And of these patients, you can see that those, about 40% overall, that were in the elevated risk group had an elevated rate of recurrence and a substantial benefit from radiation therapy. The patients in the low risk group, again, 1%. So the interesting thing, it's not much different than what you saw for the overall cohort in each of the studies. It's saying that the clinical pathology isn't that far from a coin flip. It's not driving the way these patients are moved from low to an elevated risk group anywhere to the degree that we would have thought. And of course, we've already learned this in invasive disease, and that's why we're using other biomarkers to be able to do this. It's also true for radiation therapy. So I wanted to pause for just a minute and before David came up and just see, are there any main questions about the data that's presented that we can have a discussion about briefly? And then we're going to talk about what does this mean in terms of implementation?
So Troy, can we go back to that RTOG slide? Because I feel like there's a lot there. Are there any questions specific to RTOG 9804 criteria? A lot of these patients that look weak and pop low. And what are we doing with those patients today? And do you see value in incorporating Decision RT into that patient type? Because basically what the data is telling us is, 50% of the time they're being reclassified either way, right? But I feel like in my conversations with physicians across the state, a lot of folks, that could be that group that we're missing.
So let me ask a implementation question. How many people take all the DCIS cases to tumor board? Wow, that's awesome. So often it's a smattering, and there's select cases that go to tumor board for DCIS because it's DCIS. It's great if they all make it, but it creates an excellent opportunity to talk about risk stratification there when everybody at play has a voice and you can see what the data is telling you. So I think it's a great opportunity if you do take those cases, that particularly when they meet criteria like this, you can have the discussion to say, we might have considered avoiding radiation therapy, especially considering other factors, but the test may tell us something very different. And that's really what these two gentlemen are going to talk about, are specific cases that point that out.
So I have a question. So maybe Dr. Woods, but what I'm hearing from providers is in tumor board, the DCIS patients are taking up a lot of time. But I'd like to get your perspective on that, because it's almost like so much discussion is going into what do we do with that compared to conversations with the invasive.
Add on to that question. And this is a question, we just recently decided to use the test at our development. And they wanted to put some criteria like not high grade. I'm thinking, what you're showing me shows validity across the board. So how do you either buy into it or you don't buy into it? You don't buy certain stuff.
So
if you do that, then tumor boards would be very simple.
it should be, and yet we have these discussions repeatedly where people who meet RTOG 9804 criteria, everyone's very comfortable running because the going in bias is that they're lower risk. And so when they convert to a higher risk profile, everyone's happy with more treatment. When it's the other direction and we're de-escalating treatment, it feels more anxiety provoking. And so you really want to see repeated studies where patients with grade 3 disease have low risk in the low risk group. So interestingly, we've been aware of this and we've been doing studies to pool 4 of our studies from multiple observational cohorts. So we have just about 1,000 patients that are being represented, and they don't include older patients. So they all have a modern baseline risk. And we're now presented at ASBS those patients who have under 50 for their age or grade 3 have the same response profiles as those patients in the opposite category in 1,000 patients, to make that point exactly. That yes, they're younger and they may be higher grade, and yet when we're calling them low risk, they end up with a very low 10-year risk. And now you have a distribution through a lot of patients to do that, not just individual studies. The other point is, I know young age is also a concern, and I'm sure it's going to be talked about a little tonight, because the knee-jerk reaction is, I really have to do everything for this patient I can. But the other side of that is, if they're really not going to benefit from radiation therapy, do I want to have that radiation therapy available if they have a new primary? Because their new primary risk may actually be the driving factor over the next 30 years compared to a local recurrence risk that's really taken care of. So those are some key points I think that we're going to try to talk about tonight.
All right. Well, my name's David Rock, and I'm a breast surgeon in Southwest Florida.
I'm going to do a quick sound check. How many people hear David in the back? Is it okay?
No? Louder. All right. So I'm a surgeon in Southwest Florida, breast surgeon in Southwest Florida. I moved there from Atlanta. And when I moved there, I very quickly realized that everybody with DCIS was getting radiation. And so I kind of asked, what's going on? And they said, well, if you send them, we figure you must want them to get radiation, so we radiate them. So I realized I was now the gatekeeper, and I was using ClinPath to figure it out. And what I learned from my participation in the PreludeDx study, and from doing this over and over again, was that I was coin tossing most of the time, because it's ClinPath will just let you down. So let's look at 3 of my early cases. Early on, we were ordering this on the surgical specimen, but I think as you'll see, we've kind of evolved how we use it now, and Jim will go over it too. Getting it before surgery now is really helpful. So here's my first case, a 44-year-old woman with a small 5-millimeter intermediate grade DCIS, ER positive, but 44 years old. I'm pretty sure she needs radiation therapy. I would send her for radiation therapy, but I get the test, and lo and behold, she's actually very low risk. Extremely low risk. Her risk of invasive recurrence is 3% over the next 10 years. So this lady I armed with the study and sent her over to radiation oncology, and she ended up omitting radiation therapy. The real question is, does she even need tamoxifen? Because I did send her on to medical oncology, but her risk is so low, you could make an argument that she's going to be miserable for 5 years for no good reason. The other thing about this, a lot of these 44-year-olds, and I don't get a lot of them in Southwest Florida, come in wanting bilateral mastectomies. They're young, they're scared, they don't want to go through this again. But if you get this before surgery and you show them that their risk of recurrence is 3%, 7% overall, you can talk them down off that ledge and get them to have breast conserving surgery. All right, so here's the first one I got wrong. Here's the next one I got wrong. 84 years old, that's the average age where I work in Southwest Florida. A 3.1 centimeter low-grade tumor, negative margins, low risk, no brainer, right? Oops. She's actually scores in the high risk range, and she has a kind of a modest risk reduction. 15% to 7%, invasive is 9% to 5%. At 84, this lets you have a discussion with this lady. What is your life expectancy? What are your comorbidities? Is it worth the benefit of this small risk reduction? Even though you do have a risk reduction, is it worth the benefit of this risk reduction to have radiation therapy? And you can really have a shared decision-making with this patient about whether or not she wants to go on for radiation therapy. All right. I'm going to get one of them right sooner or later, right? 72-year-old, high grade, 16 millimeters, hormone receptor negative. And I'm thinking, yeah, I don't like high grade, it's pretty big, hormone receptor negative, got to be high risk. And it was, I got it right. But what's really impressive about this is she pegged the needle to the right. She's extremely high risk. And so she gets a huge benefit, 65 to 75% risk reduction. And that's great. And in a 72-year-old, she's still under 10% or at 10% if she gets radiation. But 72 in Southwest Florida can be very healthy, and she may be looking at a long lifetime. And so this patient now might be even thinking about a bilateral mastectomy because of her high residual risk, even with radiation therapy. So again, if you get this before surgery, you can have these kind of discussions with these patients. Very helpful. So Jim's going to show you how he's evolved more than I have. Oh, the key is you have to get it on everybody, because otherwise you're just tossing a coin. And you know, to your point, if they're grade 3, we're not going to order it. If they're under so and so, we're not going to order it. You can't do that because you just can't predict. The biology predicts it, not the patient's characteristics.
So Jay, with all of your PCIS patients, when on imaging, if the microcalcifications cluster is less than a centimeter, are you running it off the core on all of those patients then to
Yeah.
help guide your treatment?
I try and run it off the core on every patient now. And usually, as soon as they get referred, we'll order the test so that we try and get those results by the time they get in.
I think that's awesome because, you know, just the travels throughout the state, so many surgeons feel that this is a radiation test that the RADOC should be ordering, right? But I think this is great that you guys are sharing your perspective, because at the end of the day, I don't know, I feel like the surgeons need to own it, right? Because it's helping not just radiation, but the surgeons with their treatment plan as well.
Exactly.
I mean, you brought it up in regards to, we like to say all the time that whether anybody likes it or not, the surgeon is going to decide who gets radiation. Because if you're not sending them over, and we talk to the RADOCs all the time, and we always ask them, going, "You think you're seeing every one of the patients that's coming over?" And they go, "No, we're not." And I go, "Well, if you would order this test and you look back at that surgeon and say, I promise to use genomics in order to help judge, then I guarantee you're going to see more of those patients come over." And trying to find that champion RADOC as a surgeon, you're going to become the hero because you're the referring back. And so ultimately, as you pointed out, they go, if you send them over, guess what? I just think they need a haircut, right?
Right.
And that's not necessarily exactly what we always want to have. So I think using it this way and using it for on the biopsy to send them and arm them not only to the surgeon with information, but to then walk them over to the RADOC and say, I'm going to refer everybody over, but I'm giving you power with information to have that discussion, right?
Well, not only that, I think you're shortening the turnaround time.
Exactly.
And if you believe that, you know, the longer the time interval, the greater chance of local control, you want to get these patients to about 6 weeks with surgery.
Yeah.
Yeah, a 2-week turnaround time. I know that would be, you know, on the MBCC with the chemotherapy. If I wait for the patient to see me and they're already 4 weeks out or 5 weeks out, then you have the planning and you have the insurance approval. That adds up.
It truly is helpful to have a lab who backs your technology desires. Because it's, once again, it's akin to PreludeDx. When it first came out, the medical oncologists didn't want to look at it. They thought it was an abomination that any surgeon should be working in their domain. And the bottom line is, if I left it to the surgeon, to the specialist, the surgeon would want ordering it, but if I left it to them, it wasn't getting ordered. So I forced the issue by ordering it on the floor because, like you said, the timing is critical and the patients benefit by it. And your case before was the perfect example of why we need to have it for surgical management and have that discussion up front. We might not think a 7mm DCIS with high risk is a reason to do a mastectomy, even if they get radiation and they're high risk. But there are patients who are scared, and it goes on both ends of the spectrum, supporting and declining.
We're changing the paradigm for patient seems to be.
Yep.
So 2003, everybody had chemo for patients. So it's no different, it just takes time.
We have to either trust the technology and understand genetics.
And with the randomized data now, I mean, it really already went right. I've had it for 4 years now. When the data comes out, and it's randomized, it's predicted, it's here, so.
Well, I think it's awesome tonight because we have surgeons in the room, radiation oncologists in the room, medical oncologists in the room. And I think it's awesome because it's truly a collaborative approach, right? Where everyone sitting at that tumor board should be in the know of when Decision RT is all about. Because as a memo, you're controlling hormone treatment, right? As far as the toxin goes, whatever you're putting them on. So I think this is great. And then Karen, you're going to have your
So I could not have gotten this through at my hospital. They were convinced that they were doing unchecked CIS. And who was I? Nobody, just a doctor, fellowship trained breast surgeon. We have dental surgeons and we're good. We don't need your input. But when Dr. Woods was interested in looking at it, and he actually took the bull by the horns and he lobbied for it and he pushed it at the tumor board conference. So it wasn't just me asking for it. And I'll tell you, when I was in Alaska, as you guys know, my radons would radiate anything, and you didn't even need to have cancer. Just saying. So they were definitely offering the test. Right, yeah, right. Exactly.
But because you made a point about size matters.
Yes, it always matters.
What was that comment? Before Jim goes, I want to make sure you all know that if anybody doesn't eat that bread, I'm taking it with me on the plane tomorrow, so just pile it up in the middle.
That's so good.
All right, Jim.
Well, thank you. So, yeah, I want to just speak to just a couple quick points before I get started. One, there are a lot of parallels with invasive breast cancer with this. We're going to talk about it at the end. But again, our radiation oncologists have evolved. I feel like I'm in a very fortunate, and our radiation oncologists don't feel the need to radiate everybody. And just like our medical oncologists, who if I send them a breast cancer patient without a mammoprint result, they are calling me up wanting to know where the mammoprint is. And our radiation oncologists are getting to be the same way with this test now. If I send them for evaluation and I haven't run a Decision RT, it's almost like they're getting a little angry with me because it's almost a little bit of a waste of the time because it's still a piece of the puzzle that they need and it's good data. And then the last point is just in my defense of the pool. So, yeah. So thank you, Edwin, for bringing that up. I was online watching some of the meeting till the system went down. And that was my initial goal. But my wife is with me and she challenged me. She said, well, you're going to be in the meetings all day because you always are. I said, no, I'm not. And that was it. I just had to dig my heels in. So no matter how bad I wanted to be at the meeting, which of course was really bad, I'd much rather been at the meeting than at the pool. I did this for my wife because I'm that kind of guy. So anyway, so I'm going to go through a few studies and I'm going to, David touched on some of the issues, but as I've moved along and I've ordered this test more and more and more, I've learned a lot about it and I've started to use it not differently, but using it to justify different ends in certain situations. So this patient is just your standard patient, 74-year-old, very healthy patient, very vital. Her significant other happens to be a physician in town, is retired. Her best friends are retired oncologists. So I have all these doctors, calling up. This guy wants to know why you're not running a HER2 on my DCIS. And I have to say, well, because that's why he's retired. We don't do that. And HER2 is baked into the cake in these tests that we're running. And so again, very healthy, but high grade DCIS, only 4 millimeters, ERPR negative. Did not meet good risk criteria. So did have a Decision RT run and came back with a low risk score and, a very low 10-year recurrence risk. And again, we discussed this with her. Again, she has physicians in her family. And so we sent her for a radiation oncology opinion and she opted not to have radiation. So again, this is one where you would consider sending her for radiation therapy, or she would consider radiating her, but because of the data you get back, you don't. So that's the easy case. And then the other ones are a little bit more complicated. So this patient is 71-year-old. She's been a patient of mine for a long time. She's very healthy. She presented to me a while ago, having already been treated in 2004 for DCIS in the same breast with a lumpectomy and radiation therapy. She took tamoxifen for 5 years. And then she had a new screen detected DCIS recurrence right in and around her scar. Her DCIS was palpable. And on core biopsy was grade 3, ER positive of 60% and PR negative. She had an MRI which showed a 3 centimeter enhancing mass associated with her scar from her prior lumpectomy. So she wanted breast conservation. And so we did a lumpectomy on her, given the fact that her breast was in good shape from her radiation back in 2004. We considered doing a lumpectomy. If we got clear margins, we could do brachytherapy if she needed radiation. And so she had 2.6 centimeters of DCIS with close margins, but they were clear, and considered brachytherapy, but we just ordered Decision RT. And she came back similar to David's patient with a really wicked high decision score. I mean, with a very high recurrence risk, or a high recurrence risk and a moderate recurrence risk, even after radiation. And this is a patient, again, who's been through multiple biopsies, been through a lumpectomy and radiation, been through a second lumpectomy, is fit, is active, is healthy, lives on the water, likes to get out on the water, and just didn't want to deal with this anymore and didn't want to deal with the risk. And so she opted for a mastectomy without reconstruction, which was her choice. But again, this was a patient that, did not meet the good risk criteria, but had really bad biology. And I called Troy about this, and it was not a long discussion, except to say, I really think that this patient might need a mastectomy. So again, it was helpful for her to see this data, to know what her risk was, and help her make that decision instead of going through more radiation therapy, potentially more biopsies and a recurrence down the road. So this is an interesting patient I just saw and I just operated on before I got here. So I don't have final pathology yet, but she's 40 and she came into my office with a small area DCIS found on her first mammogram. And I went into my usual spiel about lumpectomy. And then she said, just stop. I just wanted to tell you something. She said, first of all, I'm a widow. My husband died 3 years ago of metastatic colon cancer, and I want bilateral mastectomies because I don't want to die of this breast cancer. And so that's where we started. And so it took me a little while to kind of, and again, I don't ever try to talk people out of things, but I want them to have all the data going forward so they can make at least informed decisions, whether I agree with them or not. So we talked about an MRI, we talked about sending her to a plastic surgeon. We talked about Decision RT. The MRI showed minimal enhancement around her biopsy clip. We sent her to the plastic surgeons and sent the Decision RT. Well, her score came back incredibly low. And that combined with the fact that, again, she was ER/PR positive. She met with the plastic surgeon. And after talking to the plastic surgeon about nipple-sparing mastectomy and implant reconstruction, she basically said, all right, I'm just trading one anxiety for another with worrying about my implants as opposed to my probable non-recurrence. And so ended up opting to have a lumpectomy, which she had on Tuesday before I came out. So I don't have the results yet, even though I keep checking. But again, I think this is another way to use this preoperatively. I don't use it in everyone preoperatively. I use it in select patients preoperatively. In a patient like this, where I feel like if the radiation is going to be an issue for them, if it's going to change their decision, and then I do send it on the core biopsy. And I'm surprised in how many patients that applies to. So I do send it quite often, but I couldn't say I send it on everyone preoperatively. So what I've learned from using this test over the years is that, and this sounds silly, but DCIS is non-invasive breast cancer. And when you sit in tumor board and you hear things like, oh my gosh, this is estrogen receptor negative DCIS, this patient absolutely is going to need to be radiated after lumpectomy. And as we're learning from this, it's just not true. And there are, the test provides you additional insights beyond estrogen receptor negative, beyond grade, as Troy went over with regards to grade. There are genomic testing parallels, as I alluded to before I started. It's just that it takes a while to get people to buy in. And I think you are now at that buy-in point with the level of data that you have. But again, I send this patient to a radiation oncologist without this test. They're calling me up, wanting to know what their Decision RT showed. And so the other things that hold true is that we know younger women with invasive breast cancer, stage for stage, have more aggressive disease. but we don't treat them anymore just because they're premenopausal. We treat them based on genomic data. And then we even have gotten to the point now where we look at the genomic data, and in some clinically low risk patients who might be genomically high risk, we're going to alter our treatment a little bit based on that. We might de-escalate our treatment. And the same thing applies to this test, where women that we think automatically should have radiation therapy for their DCIS, when we get their genomic test back or the Decision RT back, we're starting to learn more about their biology. And it's really important to treat based on biology and not based just solely on ClinPath. And so I think more information makes for better consultation. So again, if you can order it before the patient is referred for radiation oncology, it helps radiation oncologists. And although DCIS is a non-obligate precursor for the development of invasive breast cancer, it really is a risk marker, right? It's a risk marker for the development of invasive breast cancer. And until now, we've never had really good ways on knowing what that risk was. And now we do have good ways in figuring that out. And so we can better counsel the patients with regards to that. And that brings up the point, as David said, why should you send this on everyone? We should send it on everyone because we're not using ClinPath anymore. So if you have a patient with 2 millimeters of DCIS, the knee-jerk response way back when, a few years ago, was we're not going to radiate them, so we don't need to worry about it. Well, that patient has a high-risk lesion, and that lesion might give them very high risk for the development of invasive breast cancer going forward. And so you should send it because it's almost similar to atypical ductal hyperplasia, right? When we look at a patient with ADH, we calculate their risk on the presence or absence of ADH, not on how much is there. And this is a similar scenario, right? It's not about how much is there. It's about whether or not they have DCIS and what their risk is going forward because they've shown the capability to develop that disease. And so that's why I order it on everybody. It doesn't matter to me how much disease they have. I'm trying to do a risk assessment on them and not necessarily a therapeutic assessment, although the benefit of this test is I get a therapeutic assessment too. So I get both. And it can, and as David alluded to also, it can guide post-op hormonal therapy. If you see a patient with, like he had and I had, with a 3% risk of invasive breast cancer who's 44, you're going to put that patient on tamoxifen for 5 years to give them a 50% risk reduction, i.e. 1.5% risk reduction and a 1% risk of uterine cancer, and making them miserable for the next 5 years because they have hot flashes and they gain weight and they have blood clot risk, which, as you all know, is real. You've treated enough patients. You've seen young patients with blood clots or strokes on tamoxifen. So if they don't need it, they shouldn't be on it. And if they do need it, they should be on it. So again, and then lastly, as I showed you with my 40-year-old patient, if you get it on the core, you get it preoperatively, it can really help you make good surgical decisions and help in, the whole shared decision making is so important now. We really need to include the patients on those decisions, whether or not it's a mastectomy or a lumpectomy, or whether or not it's an 84-year-old who has elevated risk but gets minimal benefit albeit but minimal, and whether she wants radiation or not. So that's where the test has been incredibly helpful. And so last slide, just the biggest roadblocks is just really changing old habits. DCIS is a surgical disease. Most DCIS patients are going to be, all DCIS patients are going to be cured. Most of them are going to be cured surgically, and the other half are going to be cured with a combination of surgery and radiation therapy. But they're all going to be cured. We're just trying to prevent local recurrence. And we have a clinical bias, as we talked about time and time again: grade, age, amount of disease. We have to get away from that and stop selective ordering, stop picking and choosing patients, as you said earlier, not ordering on grade 3 patients while you're irradiating 40% of patients that don't need it. So stop the selective ordering and order it on everyone. And then navigating the paradigm shift. Again, 50% benefit does not mean half the patients benefit. Hi, Barry. How are you? Don't drink my wine like you usually do. You're good. I'm not active. You can have a sip. Yeah. Oh my God, we're being recorded. I forgot. And then again, just ordering on all reasonable patients. Now, if you have a 90-year-old that you're not going to do anything to because she's wheeled into your office on oxygen, and somehow the radiologist biopsied her, maybe that's not the right patient to order it on. but you get my point. And then you can also use it to de-escalate treatment, like you're in your 84-year-old with a higher risk disease. You know, she can get partial breast radiation and help with her local recurrence risk. I think, is this, that, I was gonna say, I don't remember making that.
Thank you, Jim. So this is a quick summary here. So we have a number of studies that we've been able to talk about. In each of these, a little louder. There we go. So just a quick summary, and then we could talk about a few other things while we enjoy a nice dinner. So we've seen in study after study from US sites and from Europe and from Australia that we're predictive. We identify those patients who are getting a substantial benefit from radiation therapy and those patients who are getting very minimal to no benefit from radiation therapy. We're able to have a lot of confidence now because not only have we done this in observational studies, we've done this in a randomized clinical trial cohort. So there wasn't a bias in selection. There wasn't a bias in clinical pathology. So it isn't about either of those. It's not a fluke that it just happened to work in an observational set. And the last one is when you look at this comparatively, you're reclassifying such a high percentage of patients. You just don't know where that patient is at based on the historic gold standard of clinical pathology that doesn't have the information that it really needed to have. So together with the biology and the clinical pathology, you have a much better tool to be able to make an informed decision for how to treat the patient. You can have the opportunity to run this up to a centimeter off of a core biopsy. The sampling is great. And I'll tell you from our lab's perspective, often we will go back and ask for the core biopsy because that's where the tissue is. So it's not shocking. Sometimes you see the scraps left over because they basically did a therapeutic core biopsy. And it's not surprising. So particularly in a centimeter and under. So I believe we have a test that's helping you to make the decision. And what we'd like to be able to work with you to do is be able to make this work within your clinical practice and also within that tumor board setting. So you have the tools to be able to present the information and why it's valuable. So I really appreciate your time and paying attention during dinner, and we'll open this up if there's any other questions.
Obviously, as physicians, we always want to do the right thing right for our patients. However, that being said, some physicians like to rationalize why they're doing something for other reasons. So I think having surgeons sometimes being a gatekeeper is a very good thing in this setting. And I think it can be very important for therapists to discuss.
I appreciate that. And I think that from what I've seen across the US, the physician that the patient is going to see repeatedly is the surgeon, their home base. So you're owning that patient for the next decade, and you're part of that decision process for how that patient's going to be treated. So having that information available for you and your patient, I think, is important.
I made a comment, Andy, when you're talking about a 40-year-old patient, you're getting a 10-year risk, you're likely to live well.
Absolutely.
So how do you?
Absolutely. So we've looked, yeah, so it's a great question. So in a number of studies, you see this in the most recent publication from McCormick on 9804. You see this in the older randomized clinical trials like SWEET ECAS or UKANZ. When you look at the risk profile for recurrences out to 10 years, they're starting to plateau by the time you get to 10. And when you look at the rates of progression after that point, they mirror the contralateral new primary risk for development of new tumors. So it's not really about a local recurrence risk after 10 years. It's about managing a new primary risk, which is a different set of issues. So a patient who's 44 and they're expecting 3 decades, and they're expecting about 0.5% per year or 5% per decade for 3 decades in each breast, their lifetime risk is about 30% from that point to where they, based on mortality tables, are likely going to live. They may have a 5% local recurrence risk reduction with radiation therapy, but the bigger question is that lifelong risk that they're facing from both breasts now that they have demonstrated they've had DCIS. So I think there is a role for hormone therapy. I think it's an important question in chemo prevention. It's just a different question than are you using it to deal with local recurrence risk?
I think that needs to be part of the discussion with that 4-year-old. And it was, you know, you don't need a mastectomy to treat your current disease, but if you want to talk about your risk going forward, you know, what is your risk of a new primary breast cancer? That's an absolutely legitimate discussion of that, which we have. I think the whole implant can show that.
You know, I'll ask just a slightly bit off topic. So we've had from the chemo prevention studies for DCIS and secondary recurrences, we had TAM that was initially prescribed at a very high level in terms of therapeutic dose. And now we have the low dose available for prevention. I'm just curious what people are doing. If the patient isn't able to tolerate the higher dose, do you try prescribing the lower dose if they're a younger patient and you're worried about prevention? And we happen to have a person right here that we could pick on. Symptoms, yeah. Low dose. Yep. Yep. The reason I mentioned that is because, again, you have a question about how do I manage local recurrence risk over a decade? And how do I manage lifetime risk now that a patient's been diagnosed with DCIS? And those are two different questions. And there's a role for therapeutics in both of those. And I'm really glad personally that there is an option for a lower dose to help with chemo prevention if you failed off and you can't do it, and realizing, yeah, it'd be great if everyone can tolerate the higher doses because they've been proven to be very effective, but not everyone does. And so it's great there is an alternative.
I think one other point that I think both of the physicians here brought up is that a low score is low does not mean no, right? So just keep that in mind. This is more information. It's risk assessment. It's risk, how averse. Everybody's going to be slightly different. You know, Jim had a patient walk in that was going to be dead set on this is the pathway, and new information when I'm going to go a different route. You've got all kinds that and I know the rad-oncs sometimes push back. They're like, well, it makes my job harder if it comes in and I still think that they're high risk. And I know we argue back and forth with them all the time of going, I think Pat Whitworth said it best when he said, we always thought that the pathology was gold standard. And really when you scrape it off, it's more like brass, right? So you're basing the fact of how you're supposed to treat off of what we know is flawed technology, right? So having new information is not bad, but it still doesn't mean that you can't have that conversation. I think as Troy pointed out, if we are 0 to 2, usually they're not treated. 2 to 4, there's all kinds of information that goes back and forth, but 4 and above, about 95% of everybody gets treated. So as you're speaking with your rad-oncs, just know that just because it comes in low doesn't mean that you still can't have that conversation back with the patient. That's what a consultation's about, right?
There's patient risk preference. There's the pathology that has to go with it. And one of the questions that always comes up with DCIS is, do I think this is a skip lesion? And you often wonder that, particularly depending on the size and how it presents. And if it is a skip lesion, you're wondering what else is in the area and whether or not you do. I mean, there's other factors besides it's a nice focal DCIS that I'm considering. So there's other factors to consider. That's the main takeaway for your radiation oncologist.
I wanted to ask Dr. Gabori, because he's got extensive, clinical utility, a lot of use of the test. Can you share a little bit with the group how you incorporated it into your flow or your experience?
Yeah, I think that most of us here, I imagine, are fans of escalation therapy when necessary. And most of us, I think, are kind of, hoping to get to the point where de-escalation radiation oncologist, and I think Pat and others that kind of touched on it today and yesterday, just about the significance of the multidisciplinary approach, because it's a science that we've believed in for many years now and have brought to our tumor boards, but we're still kind of in that beginner phase of acceptance for everyone. And I think that it's another tool in the tool belt to kind of hopefully deliver the best possible care for patients. We were part of PreludeDx, and we really, hope that we're making the right decisions for our patients. And I think these meetings and discussions are important, and something for our surgeons to take home to our team. Hopefully do a better job for our patients in the future. There's definitely a learning curve, I think, for the team, for questions about the radiation standpoint, the hormone therapy afterwards. Is there like an ultra low group maybe that can do nothing? And I've wondered that with the extrapolation of the patients that really can get away with maybe doing less and less therapy than what we used to. It's just tough because you don't want to overtreat per se, but there's we definitely don't want to undertreat either, and that's the hesitation I think we have that I've on a personal level experienced over the years. So I love these conversations, and I think we're on the right track for sure.
Well, I appreciate the lively discussion. It's a pleasure to meet with all of you. I'm sure we'll have additional discussions, and I imagine we'll be having a discussion later at the bar maybe. But I really, I really do appreciate hearing all the different perspectives that you face as you're working with patients and trying to make these decisions. Because the more that I learn, the more that we can understand about the process, the better off we can be able to evolve the tool to the next step. And we're, of course, always interested in taking that next step. And so as a little bit of a teaser, I'll say we are going to be doing a second phase of the registry. It is going to be focused on patients who are typically often grade 3. And we're going to be focused on the decision changes in radiation therapy based on these patients with higher risk profiles as a second phase of the registry. So we have data that were presented at ASBS that shows just how dramatic that is. And it really does identify subsets of patients who have that 40 and 50% risk profile. And on the other side, some of them are at a 5% risk profile. And so just because they're grade 3, that does not necessarily mean you know what you're doing with them. And the data has borne that out in study after study. And so that's another phase that we're going to be looking at for the registry study.
My question is how many of those are the grade 3 ones that actually were not affected by the test for decision making?
So I think what's interesting is in our study so far in the registry, we asked a question about, do we treat or don't treat with radiation? What was the recommendation, yes or no? That was the main focus of the primary endpoint. Now the question that we're going to be asking is not just whether you treated, how did you treat? Were you considering APBI for a patient who has that very high risk profile, or did you opt for whole breast? Did you consider boosting, or are you going with a standard dose? So here's the part that I thought was illuminating. Only 30% of 2,500 patients in that whole study, only 30% of them got boost therapy of the ones who got radiation. Used to be a lot higher, now it's a lot lower. And so the question is, if you have a patient who has a significant risk to begin with, is that the patient you're going to consider to boost more? And right now, we're not asking those kind of questions in the registry per se. We're at a higher level. So we're going back, particularly for high-risk patients, to ask the other question. Another one is, if you're ordering off the board, which a lot of physicians are now, and you have that very high-risk profile, is it changing your decision for how you're doing your surgery? Are you thinking about margin management differently? Are you thinking about a mastectomy? Is that part of the conversation you're having with the patient? So now it's not just a question of treating or no treating, it's about implementing standards of what kind of treatment might be appropriate. It's the next step of using the test. And so that's what the second phase of the registry will be about.
All right, so to our speakers, we thank you very, very much. Troy gets to eat now, which is nice. So he pointed out to me at the bar the other night, which I think I've been at multiple times, so that it's been a 9-year journey. So sometimes you kind of think about how quickly these tests are going and people go, well, how long has this taken? And it's been 9 years to get here. And we are at the cusp of doing some very wonderful things, and the momentum is really picking up. So as you are out in the field, please let us help you. If you've got rad-oncs that you can set up appointments with, that we can come in and educate, we will do the Zooms, we'll have Troy come in, anything that we can do in order to kind of drive that, please allow us to help you, because I know that that's the more difficult situation in the conversation, right? So we thank you for your time tonight. I know everybody's usually busy. Absolutely wonderful. Oh, and we are Medicare approved. I want to make sure from a billing aspect, we have, because sometimes the rad-oncs will ask, we have performed over 10,000 clinical tests. So in 9 years, we've performed a lot. We have our own PLA code, which basically the AMA have given us because we give something that no one else can do. And ultimately, again, we are the only test that is predictive and prognostic in regards to radiation benefit, okay? So you've got the ammunition. Please allow us to help you in any way that we can, okay? And I do appreciate all your time tonight. Thank you.
Thank you very much.
Barry gets the bill because he came in late.
I'm sorry. I thought it was a